Our presenter today, many of you know, is Dr. Suverta Bhayana. She is our new medical director of both kidney and kidney pancreas transplantation. She's been with us since last year, approximately a year. Trained in nephrology in Seattle, correct? And Houston. And came to us from a transplant center on the East Coast. I forget the name of the Hoboken or something. Hoboken? Hackensack. Sounds the same. Hackensack. So
Come and Cheryl and do it. Yeah, mine was much better.
I don't know what the hell they're talking about. So she has no financial disclosures, and today she was invited earlier this year to present a similar topic at the Texas Transplant Society in Galveston, and because of the accolades and success of that presentation, we asked her to present a similar topic here. So she's going to talk to us about somewhat of a controversial topic amongst kidney and pancreas transplanters, but the role of pancreas transplantation in the area of newer diabetic therapies. You'll take care of it.
Thank you. Light? Okay. Hi, so we're going to talk about role of pancreas transplant in the era of newer anti-diabetic therapies. So the overview of presentation, we're going to review the indication of pancreas transplant. Going to talk about the advances in the management of diabetes and define the role of pancreas transplant in view of the latest advancement in the management of diabetes. So let's start with the benefits of pancreas transplant. With pancreas transplant, there's a lot of data which shows benefits of the transplantation. Some of the benefits are very clear-cut, the other ones not so. This slide shows the benefits that are very clear-cut, and there's robust data to prove that. So pancreas transplant, of course, improves the quality of life. There have been studies where people have asked patient questionnaires regarding the quality of life. They're not sticking themselves with insulin anymore, and so, of course, they report a better quality of life. Glycemic control is better after the pancreas transplant. Most patients are able to achieve a near normal glycemia and complete insulin independence after the pancreas transplant. And the microvascular disease related to diabetes gets better, and this is mostly true for diabetic retinopathy. There have been reports that indicate that after the pancreas transplant, the number and the severity of vitreous hemorrhages decreases, and the retinopathy either stabilizes or in some cases gets better. Now, these are the possible benefit of pancreas transplant, and I say possible because the data is not very clear-cut. Pancreas transplant confers survival benefit. The 5 to 10 year survival benefit after the 5 and 10 year survival after the pancreas transplant is 87% and 70% respectively. But there are very inherent biases related to this survival benefit. Both the biases related both to the donor as well as the recipient. The recipients who get pancreas transplants are generally much more healthier, younger patients as compared to kidney transplant patients. They have less cardiovascular morbidity, and their BMI is lower. So those candidates, the recipients, are healthier. And the same applies to the donor. The donors that we get the pancreas from are healthier donors. They're typically younger donors. So the survival benefit from pancreas transplant may just be a bias and not a real benefit. Macrovascular disease, when we talk about macrovascular disease, we are mostly talking about cardiovascular and cerebrovascular disease. There have been some reports that indicate that the progression and the number of events related to cardiovascular and cerebrovascular disease are decreased after the pancreas transplant. But again, the data is not very great. Neuropathy, again, there have been studies that have used the nerve conduction studies and muscle action potentials, and they've studied all three, motor, sensory, and autonomic neuropathy after the transplant. And there is indication that that does get better a little bit too. Nephropathy, as most of you know, that pancreas transplant is done in association with the kidney transplant. And again, there are some reports that indicate that the progression of diabetes in the renal allograft is much slower if the patient gets a dual organ transplant as compared to just kidney transplant alone. So pancreas transplant protects the renal allograft somewhat. But again, these benefits are not very clear-cut. So now let's review the indication for pancreas transplantation. These are the UNOS criteria for the pancreas transplant. Now, most of the pancreas transplants are done as simultaneous kidney and pancreas transplant. And in order to qualify for that, you have to first qualify and get listed for the kidney transplant. And once you are listed for the kidney transplant, both type 1 and type 2 diabetics can get a pancreas transplant. Type 1 diabetes is the most common indication for simultaneous kidney pancreas transplant, and most transplants are done in type 1 diabetics. So if you have type 1 diabetes, you should be on insulin, which every type 1 diabetic is, and should have a C-peptide value less than 2, which again is the definition of type 1 diabetes. Now, type 2 diabetes is, we all know, is insulin resistance. So in theory, pancreas transplant should not benefit much because you have a pancreas that's apparently working. But we'll talk about that a little bit more, why these people get benefit from the pancreas transplant. And there have been studies, there are several centers in Midwest that do pancreas transplant for type 2 diabetes. And if you select your candidates very carefully, meaning these are younger patients, no significant cardiovascular burden, insulin requirements less than 70 units a day, in those patients, even with type 2 diabetes, pancreas transplant can result in near normal glycemia and insulin independence. But these patients, again, have to be selected carefully. They should have a lower BMI, less insulin burden, and so on. Isolated pancreas transplant. So out of the total percentage of the pancreas transplants that are done, isolated pancreas transplant is like 10% or lower. And there are several indications for this, but the most common indication is hypoglycemic unawareness. That's not the only indication. You can get an isolated pancreas transplant if you have a pancreatic tumor and resection related to that. You can have exocrine insufficiency of pancreas and you can get pancreas transplant, but those are not common indication. Most common indication is hypoglycemic unawareness. So I'm gonna switch gear here and talk about what are the other modalities to treat diabetes other than the pancreas transplant. And we're going to start with the type 1 diabetes, management of type 1 diabetes, because that is the most common indication for pancreas transplant. And the newer therapies, when we talk about in management of type 1 diabetes, the most common or the biggest one is the insulin pumps. Now, insulin pumps by no means are new. You can see insulin pumps were introduced as early as 1960s. And you can look at that, the first picture, the guy's using a really big, cumbersome insulin pump. And as the time went by, the devices became smaller. But even with that, there was not much success with the insulin pumps earlier on. And the reason for that is that the kind of insulin they were using. So the earlier insulin pumps used regular insulin as the short-acting insulin. Now, that was the shortest acting insulin that was available at the time, but the half-life was still half an hour to 1 hour. It took 30 to 60 minutes for that insulin to act. And for that reason, it was not a good choice to be used as a basal insulin, and we needed something that had a much quicker onset of action. So because of that reason, the early insulin pumps were not successful. And the major breakthrough came in the pump therapy with the introduction of ultra short-acting insulins. So this is a newer pump, and this is how it looks like. It's like this pager kind of a device. It has this chamber which stores your ultra short acting insulin, and this insulin is delivered via this tube subcutaneously to the patient. Now, I want to emphasize that the insulin that is delivered through the pumps is the basal insulin, meaning there's a continuous supply of insulin to the patient all through the day, and the patient is still responsible for their pre-meal boluses. And this is more in line with the physiological function of pancreas. So our pancreas releases some amount of insulin throughout the day, and when you eat, there is a surge in the insulin release. So the pumps only release the basal insulin. Patient is still responsible for the pre-meal boluses, although the bolus can be delivered through the same device. So what the patient does is, based upon what they're gonna eat, they calculate how much insulin they're gonna need, and they enter that value, push a button, and the insulin is delivered. So pre-meal insulin is delivered through the pump, but calculated by the patient. So after the introduction, as I said, of short-acting or ultra-short-acting insulin, several pumps became available on the market. And so several pumps became available on the market. However, and this is early 2000s or mid-2000s, and although there were several devices that were available, the data did not show any significant benefit of using an insulin pump versus multiple daily injections. So the data, these pumps were either as good as multiple daily injections or maybe a little bit superior to them, but not a very robust data. Then another device that became available after the insulin pump was the continuous glucose monitors. Now, this is a device which is, again, a pager-like device which is inserted subcutaneously to the patient. And this provides a real-time glucose readings and data about trends in the glucose levels. It reads your blood glucose values under your skin every 1 to 5 minutes. And the biggest advantage is it provides the alarms. So if it detects hypoglycemia, an alarm goes to the patient. And not only that, if it detects a trend towards hypoglycemia, it still sends alarm to the patient. Now, the early glucose monitors or the continuous glucose monitors that were available, they were not FDA approved for the treatment of diabetes. Those monitors were only approved for the monitoring of the blood glucose level. In other words, if the patient had to inject insulin, a pre-meal bolus, they still needed to check their glucose via regular glucometer and use that value to inject insulin. They could not use the value on these continuous glucose monitors. And the reason was because they were not very accurate, the early ones, and they're inserted subcutaneously. So what they're actually measuring is interstitial fluid glucose value and not really your blood glucose value, which is not very different because the cells are totally permeable to the glucose. But even though these devices were not used to treat the diabetes, the patients who were using these devices reported a much better glucose control as compared to people who were not. And the reason for that was now they were monitoring their sugars very well, and they had more data points. They knew what their blood glucose did or during their day. And more importantly, they became reassured. They were able to inject themselves with higher doses of insulin and treat their diabetes better because they knew if they got hypoglycemic, they'll get an alarm. So that reassured the patients, and because of that, they were more aggressive with the management of their diabetes. So the studies did show people who were using these devices did better in terms of their glycemic controls as compared to the control subjects who were not using this. So after those two devices were introduced and became functional, this was the first landmark study that combined the use of a continuous glucose monitor with an insulin pump and compared that to the patients who were using the regular multiple daily injections. So this was a 1-year multicenter randomized controlled trial that compared the sensor augmented pump therapy, meaning the glucose sensor as well as the insulin pump, versus the multiple daily injection. And the primary endpoint on this study was change in the hemoglobin A1C levels. This study included only type 1 diabetics. There were, I think, around 480 subjects, and some adolescents were also included, although most of the patients in this study were adults. So this is the design. After screening for 2 weeks, the patients were randomized to either arm, and they were followed for a total of 1 year. So this was called START-3 trial, and these are the results. As I said, the major endpoint was looking at the hemoglobin A1C values. So x-axis is the time in months, y-axis is A1C. This purple line is the patients who were on sensor augmented pump therapy, and this is the control group who were on multiple daily injections. So you can see at 3 months after the initiation of sensor augmented pump therapy, there was drastic decrease in the hemoglobin A1C in the study group, and the patients maintained the decrease all through the period of the study. So there was a decrease, and it was maintained for the whole 1 year. This is another graph that's showing the hemoglobin A1C. On the x-axis, this dotted line represents an A1C value of 7. The light gray is people who were on injection therapy, and the black one is sensor augmented pump. So what this graph is showing is in the patients who were on sensor augmented pump therapy, they were able to achieve a target hemoglobin A1C value of less than 7. 34% of those patients were able to achieve a target A1C of less than 7, as compared to only 12% of the patients in the injection therapy. Adverse effects, the major adverse effects they were looking were severe hypoglycemia, ketoacidosis, and weight changes, because we all know insulin makes you gain weight. And there was no difference between the two groups, so the side effects were comparable in the two groups. So what STAR-3 concluded was that overall A1C reduction in sensor augmented pump therapy was greater than multiple daily injections, without any increase in the side effects. So this was the first study that showed a clear-cut benefit of insulin pumps. And after this study, the insulin pumps became more and more common and widespread. Now, after pumps being in use, for the newer pumps being in use for like 7-8 years, Medtronic came up with this new glucometer, or continuous glucose monitoring device, and this was again a very big change and a landmark in the management. So this was the first glucometer that was FDA approved for the management purposes or the treatment purposes. Before this glucometer, all the other glucometers, as I said, were only used for monitoring. Now, this glucometer was very accurate, and it was FDA approved for the treatment of diabetes. And because of that, the artificial pancreas became possible. So now we're talking about closed loop artificial pancreas. So what it essentially is there's a continuous glucose monitor that checks your blood glucose level every 1 to 5 minutes, transmits that data wirelessly to your insulin pump. There is a very elaborate algorithm in the insulin pump, and the pump uses that algorithm to calculate how much insulin you'll need and delivers that insulin to the patient. So this is all automated. And again, I'm talking about the basal insulin delivery. Patient is still responsible for their pre-meal boluses. And because it is a real-time thing, the insulin can be stopped if the the algorithm detects a hypoglycemia or even trend towards hypoglycemia. This is how it looks like. So this is the continuous glucose monitor. It measures your glucose level, sends this information wirelessly to this insulin pump, and there's a very elaborate algorithm in the pump. They used like very sophisticated mathematical models to come up with that algorithm. And based upon your insulin, the glucose values, the algorithms calculates the amount of insulin, and then that insulin is delivered to the patient. So now your basal insulin is regulated minute-on-minute basis, like the pancreas, like the physiological function of the pancreas. So this device was, of course, very good, but like anything else automated, safety is a big concern. So this is the study that looked at the safety of these devices, the automated or the artificial pancreas. So what they did in this study was patients who were on the previous open loop systems, which use the regular glucometers and the insulin pumps, they were switched to the closed loop system for a period of 3 months. And after they were switched, what they found was that there was a left shift in the graph, so meaning that the hemoglobin A1C improved after they were switched from the open loop system, which is the regular sensor augmented pump therapy, to the closed loop or the artificial pancreas. And what they found was when patients were in open loop system, they were able to maintain a near normal glycemia for 66% of the time. But after they were switched to the closed loop system, they were able to maintain normal glycemia or were able to stay in normal range 72% of time. And this study was mainly looking at the safety, and there was no difference in the side effects before and after the switch. There was no difference in severe hypoglycemia or DKA in these patients. In other words, the closed loop artificial pancreas system is pretty safe. Now, this is another study which modified their mathematical algorithm even more. And what they found was, so this is the light grays, it's not very nicely visible, but the light gray is the open loop system. The black one is the artificial pancreas or the closed loop system. So overall, during the 24-hour period, the patients who were using the artificial pancreas or closed loop system were able to maintain a normal glycemia 90% of time. And that amount of normal glycemia or the percentage of time that patients stayed in normal glycemia increased to 97% at nighttime. And the reason for that is at nighttime, the pump is fully automated. It is just using the information from the glucometer. But during the day, there's a human involved for the pre-meal boluses. So because of that, overall, it's 90%, but at nighttime, this is incredible. Like 97% of the time, the patient stays in the normal glycemia range. So this is mostly about type 1 diabetes. Now I'm gonna review the other indication for pancreas transplant, that is, I'm gonna come to type 2 diabetes later, sorry. So I'm gonna review another indication for pancreas transplant, which is isolated pancreas transplant, and hypoglycemic unawareness is the most common indication. So let's see what we have for that with the neurotherapy. Now the biggest thing that happens is, of course, the sensors and the alarms. So hypoglycemic unawareness doesn't go away, it's still there. But these devices are so good that they send alarms to the patient when they detect hypoglycemia or even a trend towards hypoglycemia. And not only that, the alarms are sent to the cell phones of the patients, but they can also be sent to the cell phones of the family members in case patient ignores the alarm, which is especially helpful in case of the adolescent patients who have type 1 diabetes, and mom and dad, they get the alarms too if the patient is showing a trend towards hypoglycemia. So that is one thing. And the other thing is that the amount of time the patient spends in hypoglycemia is very minimal. So hypoglycemic unawareness is still there, of course, when the patients are using the newer insulin pumps, but the amount of hypoglycemia is lowered significantly, and even if patient does experience hypoglycemia, there is all those alarm systems that help alert the patient. So what this study showed was the patient, this is the black is again the patients who were using the artificial, the closed loop pancreas, they had significantly less hypoglycemia overall and more so at nighttime, again, because at night it was all fully automated. To the same effect, this is another paper. Now, these are the two graphs in the same adolescent type 1 diabetic over 2 different nights. So this is measuring the blood glucose level at nighttime. This is the same patient. Here, this patient is using the artificial pancreas, and you can see that the fluctuations are very low at nighttime. So the patient is able to maintain the blood glucose in a very narrow range. Here, the same patient is using the open loop system, and you can see there's a wide fluctuation. And this early morning hyperglycemia is related to the release of growth hormone that happens in adolescents early in the morning that results in hypoglycemia. So this pump is not able to control that or address that very well, whereas this automated pump is doing an extremely good job at addressing that issue. And just a little bit on bihormonal system. So this is just another extra line of safety for hypoglycemic patients. So what this system does is it combines the use of insulin along with glucagon. If there is a trend towards hypoglycemia, not only does it stops the insulin delivery, but it also enhances the glucagon release. So there is another extra line of safety. And the patients who used bihormonal therapy, they had significant less hypoglycemia as compared to the control group. But as you can imagine, these are very elaborate and expensive pumps. So these are reserved for only few patients in whom hypoglycemia and unawareness is a big deal. But they are available. This is a graph that shows patient satisfaction. These are, again, type 1 diabetics. They used some diabetes quality of life and satisfaction questionnaires. And what they found was that patients who were using the artificial pancreas or the closed loop systems reported better satisfaction as compared to when they were not using the same system. This is what the patients had to say. I'm gonna let you guys read it. But patients were very happy. They felt very reassured. They were not afraid of hypoglycemia anymore, so they were able to manage their diabetes more aggressively. So overall, the patient satisfaction improved tremendously. And I want to emphasize that because we are comparing this with pancreas transplant, and quality of life is a big thing, a big benefit that patients get from pancreas transplant. But this group also reported a lot of satisfaction and benefits in terms of quality of life when they were using the insulin pumps. So the next and the final indication for pancreas transplant is type 2 diabetes, and I'm going to talk a little bit about what's new in the management of type 2 diabetes. So again, type 2 diabetes is not just the insulin resistance, but what happens with type 2 diabetes is you have insulin resistance. As a result, your body needs more and more insulin, and pancreas overworks or works harder to make all that insulin. And in the process, in the end, it gets burned out, and there is a destruction of the beta cells. So type 2 diabetes should not just be called as insulin resistant. It should be defined as insulin resistant, resulting in progressive beta cell destruction. So So how do we manage type 2 diabetes now? So the American Society of Endocrinology recommends early initiation of insulin therapy. And the reason for that is because the earlier you institute insulin therapy, in theory, you can prevent the beta cells from working too hard. And as a result, you can prevent some of the beta cell damage. Now, the recommendations are if you have a patient who presents, this is a newly diagnosed patient who presents with the A1C value of say 9 or 10, the recommendations are to start them on insulin and then add other agents and potentially get them off insulin, but try to control their sugars aggressively with insulin first so that you can preserve their beta cells. Now, the pros of insulin therapy is, of course, it preserves the beta cell function and it reduces hyperglycemia. It is the best way to manage diabetes, but it comes at a cost. Insulin makes you gain weight, and there is risk of hypoglycemia. Now, risk of hypoglycemia is the single most factor with the patients as well as the providers why the diabetes is not adequately treated in anybody, type 1 or type 2 diabetes. And weight gain is painful. Those of us who take care of post-transplant patients who are on insulin, we see this spiral all the time. The patient is insulin resistant. You have to go up on the insulin dose. The insulin makes patient gains weight. He becomes more resistant, more insulin, more resistance, more insulin. And this is a spiral that's difficult to get off. So in order to manage that, in order to manage two problems associated with insulin, namely the weight gain and hypoglycemia, the American Association of Endocrinology recommends adjunct or add-on therapies. Now, most of us are familiar with the older agents, the sulfonylurea, metformin, thioglitazone. So I'm going to focus on the newer therapies. So there are three new or relatively newer classes of medications for the management of type 2 diabetes: GLP-1 agonist, SGLT2 inhibitors, and DPP-4 inhibitors. The first two classes are associated with lower cardiovascular mortality as well as weight loss. DPP-4 inhibitors do not confer any cardiovascular benefit. They are weight neutral, so they don't result in weight loss, but they also don't result in weight gain like the other agents like thioglitazone and sulfonylurea. But I've included these agents here because out of all three classes, DPP-4 inhibitors are the only ones that are available orally. So so patients tend to prefer those. I'm going to briefly talk about these two classes. So GLP-1 analogs. GLP-1 is glucagon-like peptide, which is released when a person ingests food. There are GLP-1 receptors on these three organs. The analogs act on the pancreas. They result in insulin release. That's how they control hyperglycemia, and they decrease the glucagon release. They act on hypothalamus, and they suppress the appetite. They act on stomach, and they delayed gastric emptying. Also, they have nausea and vomiting as a most common side effect, which could be related to delayed gastric emptying. But because of these two effects, suppression in appetite and decreased gastric emptying, these agents are associated with weight loss. And as I said before, these also confer cardiovascular benefit, or they're cardioprotective. The other class is SGLT2 inhibitor. So these agents act on the proximal tubule of the nephron, and they decrease the glucose reabsorption from the proximal tubule. As a result, you excrete more glucose in the urine. Now, glucose acts as an osmotic agent, and it takes water with it. So these agents also have a diuretic effect. And because of that diuretic effect, it has hemodynamic benefits. It not only lowers your glucose and also help with weight reduction, it also has this diuretic effect, so it helps in the management of hypertension. So your blood pressure is lowered with these agents. The congestive heart failure is better managed, and there have been reports of less hospitalizations related to CHF. So because of all these hemodynamic effects, these drugs are becoming more and more popular. However, for our transplant patients, these drugs might not be optimal, and there are several reasons. Number one is these drugs have not been studied in the CKD population, and all our transplant patients by definition have CKD. The other even bigger reason is these medications, now you can imagine they're causing glucosuria. So they're associated with more vaginal yeast infections and also increased UTIs. So which is a problem in our transplant patients to begin with, and now you're giving them more UTIs. That's not going to be optimal. So because of that, I think we'll be cautious, and I don't think I'm going to use these drugs anytime soon in our transplant patients until we get at least the UTI situation cleared. So this is a little summary. The SGLT2 inhibitors, they help with blood glucose management. They cause weight loss. They do not cause hypoglycemia, and they have some renal and hemodynamic benefits. GLP-1 agonists, they decrease cardiovascular mortality, cause helps in blood glucose management, do not cause hypoglycemia. They also promote weight loss, and they have potential renal benefits. So these drugs, I want to emphasize again, have cardiovascular benefits, and we are again comparing everything to pancreas transplant. Pancreas transplant have not shown consistently that it protects your heart. So we need to study these drugs more, and the fate of pancreas transplant in type 2 diabetics will be decided once we have more data on it and maybe more trials when we are comparing these medications to the pancreas transplant. So in summary, insulin pump therapy for type 1 diabetes offers an excellent way of management of type 1 diabetes. More clinical experience with newer pumps is required before we can consider it as an alternative to pancreas transplant. So for now, I don't think anything changes for pancreas transplant. We'll continue to do the pancreas transplant for type 1 diabetes that we are doing right now. But this is a very promising therapy for type 1 diabetics. Type 2 diabetics, if I have to guess, I think we might see some decline in number of pancreas transplant for type 2 diabetics because of the cardiovascular benefit from the newer anti-diabetic medication, and that benefit is clear. The role of pancreas transplant in type 2 diabetes may decline in future. And what I think will definitely happen, we will see a decline in the pancreas alone transplant for hypoglycemic unawareness, because, as I said, hypoglycemia is very rare in the newer pumps, and there are all these alarms that alert the patient. So we will, I think, see a decline in pancreas alone transplant, because remember, pancreas alone transplant do not confer any survival benefit or anything. The only reason is hypoglycemic unawareness, because we don't want the patient to just not wake up one morning from hypoglycemia. And if we have alarms that can prevent that, I don't think we need a pancreas transplant anymore. With that, I end.